Hey everyone. So I think we're going to get started with our next talk, which is going to be a talk about climate change and kidney disease. Here are all of our standard disclosures. None of my disclosures are pertinent to this talk, but I do want to mention that I do have a few roles that are kind of outside or kind of related. So I work with the ASN on policy and advocacy, have helped write their statement on climate change. I'm their delegate to the Medical Society Consortium on Climate Change and Health, which is an interesting entity. It's basically an entity that formed based off of the privilege that we have as physicians and the evidence that people listen to physicians and saying, let's take advantage of that privilege and kind of utilize that. And then other things that are more local. And so our objectives today, I'm actually just going to try to fix something here. There we go. So our objectives today, we're going to start with a little bit of background. We're going to go wide, we're going to go deep, and then we're going to talk about next steps. So this is more of a background and content talk, less solutions-oriented, more problems-oriented. But I just want to show you, as someone who kind of stumbled into this space, how broad it gets, and try to motivate you to look at this in your spaces as well. So I want to start with the eye-opener to me, which is dialysis. And dialysis is miraculous, but is incredibly resource intensive. And to give a quick just overview of what dialysis is. So in dialysis, you have people with kidney failure, and we basically remove uremic or kidney toxins using diffusion and convection. So we take blood out of your body, you have a semi-permeable membrane, and then there's a fluid on the other side, and you just have toxins go down their concentration gradient, and that's how we clean your blood. And so we're one behind, sorry. I guess this looked a little different. All right. And so, sorry, I'm just gonna fix this because the slide it's showing me is not the slide that you are seeing. There we go, that's better. All right, so water use in dialysis is tremendously high. That dialysate that we use, we run it at 800 mLs a minute. So if the average dialysis treatment is 4 hours, if you're using 800 mLs a minute of dialysate and you're dialyzing someone for 4 hours, use 192 liters of water to dialyze one patient once. But that water actually needs to be made ultra pure or pure. So we actually use 3 times that amount in order to generate that 192 liters that we use. So we actually process almost 600 liters of water, and then what we end up with is 192 that we can actually use. And so if you dialyze 3 times a week as a standard, you're using 576 liters of water a week, and for one patient per year, you're using about 30,000 liters of water. So dialysis is incredibly resource intensive. If you were to look at dialysis not from the patient perspective, but as a nephrologist, I go round in a dialysis unit. If my dialysis unit has 20 chairs, each patient in a chair is dialyzing for 4 hours, that means that 192 liters per treatment, that's 3,840 liters of water per shift. We usually run 2 shifts a day. We are using 8,000 liters of water every day to dialyze our patients. And to get that 8,000 liters of water, we're actually processing 24,000 liters of water. And so this was eye-opening to me. If you are at Rhode Island Hospital on the 9th floor, there is a water treatment facility, which is what we use to generate water for dialysis. And the first time I saw this as a renal fellow, I said, wow, I know that this is an incredible therapy, but I did not know what it takes to get this incredible therapy. And so that was kind of my eye-opener to the resource demands of dialysis. And what I'm going to show you is that there is a bidirectional impact here, that weather and climate can impact kidneys. Kidneys are very demanding on resources, and so you rinse and repeat, and you get a bad cycle. And so I'm going to not go too deep into this because you've already heard this twice, and you don't need to hear the state of the science a third time. But what I just want to highlight is a couple things that you heard earlier, that globally, the healthcare system is responsible for about 4.4 to 4.6% of greenhouse gas emissions. In the US, we have American exceptionalism. We're at 8.3 to 8.5%, and this is growing. If you were to look at the United States healthcare system as a country, we would be the number 7 producer of greenhouse gas emissions of any country in the world, just comparing our healthcare system to every other country's entirety. Modifiable environmental factors contribute to 1/4 of global deaths and 28% of deaths of children under 5. 40% of the US population lives in areas with unhealthy air quality. And as you've seen, there are a lot of ways that you can look at the environment. The environment has many components. Today, we're going to focus largely on heat. We're going to meander a little bit, but we're going to focus largely on heat. We can do this for 8 hours. There is a lot of depth here. You have already seen this slide, so I am not going to make you hear about it again, but I do think it's a good way to overview. And as I was trying to think about what are the ways in which the environment affects my kidney patients, this was a great way to go about it, to think about individually extreme heat, air pollution, water and food supply and quality, severe weather, environmental degradation, degradation of living conditions, changes in vector ecology. And so let's give a little background on chronic kidney disease. So 1 in 7 US adults have chronic kidney disease, 14%, that's about 35 million people. This is incredibly common. 9 out of 10 adults with kidney disease do not know that they have it. 1 in 3 adults with severe chronic kidney disease do not know that they have it. This is very prevalent and underappreciated. And so what we're going to do is we're just going to take a broad overview of major ways that you could get kidney disease and how the environment is impacting it. And then what we're going to do after that is we're going to take a deep dive into one area, which happens to be fetal development. So today's been very kind of OBGYN heavy. If you have questions about fetal development, I will not be answering them, but I will answer about the kidneys. So there's a growing body of evidence that shows the adverse impact of various environmental and occupational exposures on kidney health. What I just want to highlight here are the various ways in which this can happen. I think that anyone with medical experience is probably thinking heat-related. So one of the most common causes, probably the most common cause of acute kidney injury is prerenal azotemia, which is essentially you get deplete of sodium and you get hypovolemic and your kidney function declines. And if you replete your intravascular volume, your kidney function will bounce right back. If you've admitted patients to the hospital, very, very many of them will have an acute kidney injury, and they will have that acute kidney injury because their kidneys are hypoperfused. And as you restore perfusion, they will bounce right back. And this is what I had initially thought in terms of particularly extreme heat exposure. This is going to increase the risk of that prerenal azotemia, but it gets much broader. There's something called CKD-U, which I'm going to go into a little bit later. Endemic infections are actually something that we don't deal with as much in the US, but if you look at this from a global perspective, this is one of the more common causes of acute kidney injury and chronic kidney disease globally. And waterborne and vector-borne disease move as the environment moves. Waters and vectors are part of the environment. Things like malaria, dengue, hantavirus, diarrheal diseases. And infectious disease is one of the most common causes of kidney injury. There are a lot of ways in which infectious disease can cause kidney injury, both directly and indirectly. So you have infections like malaria, dengue, hantavirus that are directly nephrotoxic. But if you have a cellulitis, you can get a tubular injury. The tubule is part of your kidney. You can get a glomerular injury. So anyone with an infection can get a kidney injury. So there are a lot of ways in which you can get an acute kidney injury as your environment changes. And because there are overlapping environmental and social risk factors, there is disproportional effect here. This is a big slide, but I just want to show you that there's evidence to support what I'm telling you. I'm not going to go one by one into everything, but I just want you to know that what I'm telling you is evidence-based. And so just to give you some brief things here, so you see a 20% increase in admissions during heat waves with increases in AKI and nephrolithiasis. You see higher mortality. You're going to see higher mortality again. If you keep going, you'll see higher mortality a third time. You're going to see more admissions. You're going to see a dose response with temperature and admissions, a dose response with temperature and AKI, a dose response with temperature, AKI, and mortality. And the reason I want to highlight that you're going to see mortality is a lot of times if you think that this is going to be transient hypovolemia, prerenal azotemia, you would say this is important. People do not want to be hospitalized. They don't want to have an acute kidney injury. But if a prerenal azotemia does not actually cause any sort of intrinsic AKI, it is completely hemodynamic. If you were to biopsy their kidney, it looks perfectly normal. So you could argue if there's no intrinsic damage, this is not something anyone wants, but also not something that you would be overly worried about. But I want to show you, and I'll show you both that there are consequences, including things like mortality, which I just showed you, and I think that is the most patient-centric outcome there is. And I'm going to show you that there is intrinsic damage in a couple slides. I'll give you a little bit of more detail on a couple of these. So this was 150,000 hospital admissions with renal diagnoses in July to August in 1991 to 2004. They used regional temperature, humidity, and barometric pressure data from automated monitors as exposure indicators. And what they found was that there's a 9% increase in the odds for acute renal failure per 5 degrees Fahrenheit increase at a 1-day lag. So 1 day after you get a 5-degree increase in Fahrenheit, you have a 9% higher odds of being hospitalized for acute renal failure. I'm going to skip this just to keep us on time and show you what I alluded to earlier, which is an interesting study. So what they did here is they took young, healthy controls and they exposed them to wet bulb temperatures, and they tried to look at wet bulb temperatures consistent with current heat and future extreme heat events. So they started at, quote, room temp, moved up to 31 degrees Celsius of a wet bulb temp, and that was to emulate a extreme heat event currently, and then move to 34-degree extreme heat events in the future. And what they found was that you have an increase in TIMP2 IGF BP7, which I'm glad I actually got that right. That was impressive. But what that is it's a biomarker. It's a biomarker of tubular injury. So what they did is they took people, they put them in hot wet bulb temperatures consistent with current and future heat waves, and they looked at their urine to say, is your urine spilling biomarkers of injury? And they are. So this proves that heat itself is directly nephrotoxic. And so there are a lot of mechanisms in which this can happen, including direct thermal injury, rhabdo, which is a muscle breakdown, dehydration. Biomarkers have indicated, that last study actually indicated that you do get to proximal tubular injury. And what they show is that heat stress and dehydration act synergistically. Endemic infections is another way that this occurs. So leptospirosis is spread by domestic and wild animals. It's appearing in previously unaffected tropical areas. You get soil and water that's contaminated by infected animals, and lepto is directly nephrotoxic. It can also cause rhabdo. Hantavirus is also rising. You're seeing essentially a shifting vector ecology, and vector-borne kidney disease is incredibly important, and so this is something that you're seeing more of. As we move to chronic kidney disease, now you start to see a variety of other things. You see upstream kidney disease. So chronic kidney disease, if you were to look in the US, your number 1 and 2 cause are diabetes and hypertension. If you see increases in diabetes and hypertension, you will see increases in CKD. Recurrent heat exposure can result in CKD-U, which I'm going to explain to you what that is shortly. I just mentioned infectious vectors. They're back. Malaria and dengue are back. And then agrochemicals, heavy metals, and air pollution can increase the risk of CKD and increase the risk of adverse events among patients with CKD and ESKD, and I'll show you that shortly. So let's briefly talk about CKD-U. So CKD-U actually was described by Time magazine as the black lung, so they said kidney disease is the black lung of climate change, and CKD-U is what they were describing. So CKD-U is a chronic nephropathy. It is a tubular interstitial nephropathy that has been individually identified in at least 4 different places. It has been described as Mesoamerican nephropathy, Sri Lankan nephropathy, Udapan nephropathy, Baltic endemic nephropathy, and essentially what this is it is an endemic of chronic kidney disease in outdoor workers in hot, arid environments. It looks like an interstitial nephritis. There's no protein in the urine. There's no glomerular injury. People come in with high blood pressures, abnormal kidney function, typically signs that their tubules are not working. They may have a lower potassium than you would expect. And this has been identified pretty much throughout the equatorial belt across the world. And this is getting worse. And this is something that can cause very, very high rates of CKD and end-stage kidney disease. And so there is a lot of research going into what is causing this. There's a few theories as to what it is. There is one view that this is more direct thermal injury. There's a second view that this is dehydration mediated. The third, because it's largely outdoor agricultural workers, is that this might be pesticide mediated. Their theories are still out there. I would argue that it probably is going to be multifactorial amongst each of these. But this is something that we're seeing as you're seeing temperatures going up. You're seeing more and more kidney failure related to this. Vector-borne disease. What I want to highlight is that this image is going to be invalid soon. I talked to nephrologists in India. India is a big country. And one thing that I find interesting is talking to nephrologists on the coast in India. They're telling me that they're seeing infectious diseases they don't usually see because the vector ecology in India is changing. And so this is going to change, and this is something that we all need to be cognizant of. If you're working up pretty much anything, whether it's an infectious disease or anything you're working up, you have to think about endemic infections that could be causing it and what those endemic infections are going to change. And particular to the kidney, malaria, dengue, COVID-19. COVID is also directly nephrotoxic. COVID, I don't think, is moving so much with climate, but malaria and dengue absolutely are. Probably the most dangerous animal in the world is the mosquito, and the mosquito is moving. Air pollution, so I said we're going to focus a lot on heat, but I'm going to take a couple asides into other areas, one of which is air pollution. So air pollution both increases your risk of incident CKD and is associated with cardiovascular mortality in patients who are on dialysis. So the first study on the left here followed 75,000 people in 21 countries, and they showed that long-term exposure to high levels of PM2.5 was associated with a hazard ratio of 1.7 for incident CKD. And then on the right, what you have is 315,000 dialysis patients actually from USRDS. And what they showed was a correlation between long-term ambient PM2.5 exposure and cardiovascular events and cardiovascular mortality. Interestingly, one of the probably most strong associations is with kidney stones. The number one risk factor for kidney stones or one of the highest risk factors for kidney stones is exposure to high temperature. Because with kidney stones, what happens is as you urinate, the greater the concentration of your urine, the more likely you are to crystallize and form stones. And what causes concentration in your urine to go up? It's when you have transdermal water losses. If you're losing water outside of your urine, you're going to concentrate your urine. And in heat, we have higher heat-related transdermal water losses. That leads to vasopressin-mediated reabsorption of water in the cortical collecting duct, increasing your urine osmolarity. As your urine osmolarity goes up, solutes go up, calcium goes up, oxalate goes up, you get kidney stones. And so the kidney stone belt is actually rising. I joke I moved here from Philadelphia because the stone belt currently does not include Philadelphia. By 2050, Philadelphia will be in the stone belt. Rhode Island is still above the stone belt. So I joke that I moved here to get out of the rising stone belt. And the mechanism is largely dehydration and transdermal water loss. This is just to show you that what I'm telling you, again, is not just one guy's thoughts. There is evidence supporting this. But there's something interesting about this evidence. What's interesting about this evidence is most of this is looking at stone events with a 1 to 7 day lag. You're not going to form a stone in 1 to 7 days and end up in an emergency room. So there's also a thought that with heat, there's also a connection to stone dislodgement. So heat is not only going to be associated with forming kidney stones, it's also going to be associated with having acute stone attacks. So interesting evidence supporting that. Dialysis, so I opened with this. The impact of dialysis is drastic. If you look at water, power, waste, so conservatively 18,000 liters per patient per year. I know earlier I said 30,000. One of the things that we've done as a green endeavor is we've decreased that dialysate flow at Rhode Island Hospital. What used to be a standard 800 is now 500. And so we've moved from 30,000 to 18,000. But when your conservative number is 18,000 liters per patient per year, that is drastic. The power it takes to do one single HD treatment is the average power used by a family of 4 in a day. Waste is up to 8 kilograms per treatment. 1/3 is potentially recyclable, but typically not. And if you were to have a global dialysis unit, I would not want to be the medical director of that, you would use 156 billion liters of water a year. You would generate 625,000 tons of plastic waste a year and use 1.62 billion kilowatt hours of power per year. So dialysis is tremendously resource intensive. You might ask, if you do dialysis at home, would that be better? And the answer is not really. This does not actually answer that question very much, the slide I'm showing you, because actually what's interesting is that the resource demands of home dialysis are considered to be an industry trade secret. It's really hard to figure out because this is all handled by 2 companies, and most of what I'm showing you here is that there is a lot of resource utilization in getting product to patients' houses. There are 2 ways to do home dialysis. You could do peritoneal dialysis or home hemodialysis. And on this next slide, I'm going to talk about home hemodialysis, but I'm going to go back to talk about peritoneal dialysis briefly, because with peritoneal dialysis, the way that you get that dialysate, that fluid that I mentioned earlier that we make hundreds and thousands of liters of, you use much less. Instead of using 500 liters in a day, you'll lose 8 to 10 liters in a day. But it is shipped to your patients in plastic bags and boxes. Your average home dialysis patient will have a set of boxes probably the size of this width and height. And that's a monthly shipment, maybe a little bit less than the width. But they're getting monthly shipments, and of course, that includes plastic, that includes cardboard, that includes shipping. So the cost of getting it to patients is huge. Home hemodialysis is better. There are a lot of ways to do home hemodialysis, but if you look at the very top left, what's labeled as mobile home hemodialysis is about the way that 90% of home hemodialysis patients in the US get dialysis. And what they do that's different is they're shipped concentrate and they generate dialysate in their home. And they typically use much less. They're using typically 30 to 40 liters of dialysate a treatment. It's done very differently than what you do in center. So home hemodialysis is actually an option that is much more environmentally friendly. Less than 1% of people in the US get home hemodialysis. So dialysis as an industry is incredibly demanding. And so I think I've shown you, climate leads to kidney issues. Kidney issues require a lot of climate resources, and so you rinse and repeat, and we have a problem. I wanted to give a bit of a deep dive, so this is actually going to build off of what you heard in the last talk, and what I want to talk about is nephron mass. I'm going to ask you to make a couple leaps of faith with me, but I think that we can do that. And first we're going to talk about nephron endowment. So I apologize if seeing any embryology is going to give you PTSD, but here we are. So for the kidneys, at about 5 weeks of gestation, you get branching morphogenesis. At about 9 weeks of gestation, you get nephron formation. Arcades start about 15 weeks, and you get your full nephron endowment at about 33 to 37 weeks. You are born with every nephron that you will ever have. Most of you are. If you're born very preterm, you may have some post-delivery nephrogenesis, but most of us are born with every nephron that we're ever going to have. And so there's a concept called developmental programming. In nephrology, it was proposed by Brenner. In other fields, it's been proposed by others. And essentially, this is the idea that your prenatal environment and prenatal outcomes will affect your long-term outcomes. And what they noticed was, and this was in the 1970s and 80s, Brenner noticed that the people who were born preterm had higher rates of hypertension and CKD down the road. And what he theorized was this was due to nephron mass. And autopsy studies have shown that your nephron number increases with increasing birth weight and gestational age. And as you heard last time, there are a lot of things that are associated with nephron endowment: low birth weight, small for gestational age, preterm birth, exposure to maternal obesity. But I am trying to kind of highlight that low birth weight, small for gestational age are associated with lower nephron endowment. And so you get this concept of developmental programming where you end up with intrauterine growth restriction, preterm birth, and those both result in impaired nephrogenesis. You have a low nephron endowment, and now you have less functional reserve. You are not as resilient to injuries to your kidneys over time. And so in 40 of 47 studies, so this is a systematic review and meta-analysis looking at high temperatures and pregnancy risk of preterm birth. In 40 of 47 studies they reviewed, preterm births were more common at higher than lower temperatures. They classified exposures as heat waves or 1 degree increments and temperature threshold cutoffs. And what they found was that the odds of a preterm birth rose 1.05-fold for every 1 degree Celsius in temperature and 1.16-fold during heat waves. So this is again showing you the odds of preterm birth during heat waves is higher. And this is the odds of preterm birth per degree increase in temperature. So this, I actually have to highlight, I am not a huge fan of how this data visualization was done. That line in the middle is not the 1.0, the line at the left is the 1.0. So this is statistically significant, even though when you first look at it, it doesn't immediately look like it is. And so what I hope I've convinced you of a little bit is that heat events and heat are associated with preterm birth. Preterm birth is associated with downstream hypertension and downstream chronic kidney disease. There is further evidence, actually, Dr. Just, who is presenting right in the next room right now, did some of this work that you're seeing right here. And so there is further evidence looking at air pollution, finding that air pollution is associated with impaired kidney development and GFR downstream as well. I only have 5 minutes left, and I did want to save a little bit of time for questions. And so what we have is a needs assessment that says that the kidney is an extremely environmentally demanding organ. The environment changes cause damage to the kidneys. Our current treatments for the kidneys are incredibly environmentally intensive. And so our needs assessment is, oh boy. And so, but there is progress being made. So I mentioned earlier that I do a lot of work with the American Society of Nephrology. The American Society of Nephrology is convening its climate group for the first time. We wrote a climate statement a couple years ago. Writing a climate statement is important. You would think writing a statement doesn't do very much, but writing a statement allows you to have policy on paper so that you can start applying that policy to decisions that you make. So you're able to do that. If you look at the two largest providers of dialysis in the US, DaVita and Fresenius, DaVita is already carbon neutral right now. Fresenius is targeting to be carbon neutral at a global level by 2040, and the White House Climate Pledge, I believe, targets 2050. This makes sense because, as I mentioned earlier, the neutrality in dialysis is largely related to resources, and becoming more efficient saves you money. So we're in a place where, in nephrology at least, in dialysis, we are very much synchronized between our economic incentives and our patient care incentives. Northwest Kidney, which is a smaller dialysis organization, they have upgraded every single one of their water treatment facility rooms in their entire facility so that instead of wasting 2/3 of water as they generate that dialysis, they only waste about 10%. It takes about 3 years for that investment to pay off. Don't know if they're in the 3 years now, but there are a lot of things that are being done in industry to make progress here. There are really interesting things being done to move us away from dialysis as an ecosystem altogether. There are xenotransplants that are occurring. There was someone who was just transplanted with a pig kidney at MGH a few weeks ago who was discharged to home and currently has a functioning pig kidney. Moving away from dialysis as an ecosystem altogether is an opportunity to change this. There is a lot of work being done to increase home dialysis, increase the kind of efficiency of home dialysis. So there's a lot of work that's being done both in the public and private sectors in nephrology. But right now, we have a problem. And so this was, as I said, a little bit more of a problem-focused talk. I will open up for questions. This is our Division of Kidney Disease and Hypertension here at Brown, so we thank you for inviting me, and thank you for hearing about the kidney. Questions?
Yeah. How does this inform your day-to-day practice with interacting with your colleagues, talking about how clinic is set up, or the care that you deliver to your patients? Does it inform your practice, or?
It definitely does. I think going back to one of the things that I mentioned about the MSCCH kind of having formed around the privilege that we have as physicians, people listen to us. There has been a bit of a disinformation issue, and so there's a little bit less listening, but people listen to us. So when you see someone in clinic who has a kidney stone and you inform them, this is partially due to environmental exposures, a lot of times it's the first thing that they're hearing about this. So I think on a day-to-day basis, this very much informs decisions that are being made and education. I think that education, not to make this all individual, I think that we were talking about this earlier, but solutions need to go beyond the individual. But as an individual, when I'm in a room with a patient and they have a kidney problem that is partially environmentally mediated, just letting them know is a change. And then in terms of decisions that are being made kind of system-wide, I will say I am not in a leadership role where I'm the one making many of those decisions, but I do have awesome people in leadership roles ahead of me. So things like adjusting our dialysate flows, looking for ways to be more efficient in what we do are things that we've done. As I tried to demonstrate, dialysis is, I think, the low-hanging fruit in nephrology. So a lot of where we've tried to intervene has been in dialysis. I think one of the nice things about a conference like this is hearing what others are doing and hearing questions like yours, because Now I'm starting to think we don't need to just work in one space at a time. So moving towards our clinics and other care settings to see what we can do is something that we should do. And I appreciate the question because it stimulated some thought.
Thank you for the answer.
Yeah.
Thank you. As a non-medical researcher, this was an amazing crash course. And you focused on air pollution and how that elevates risks for kidney disease. But I'm really struck by how much water matters, both in terms of dialysis, but also in just hydration. And so I'm curious about how climate change impacts through both sea level rise, which increases groundwater levels, but salinity and also other sorts of groundwater pollution, and also water variability. You know, the whole of Asia will be affected when the glaciers of the Himalayas are gone.
Mm-hmm.
And so I'm curious about what you think that pathway between climate change and kidney disease will look like.
Absolutely. So I brought my water bottle up here because one of my good friends ends every talk by saying, stay hydrated. And so stay hydrated is a very simple statement, but if you think of it from an equity perspective, there are a lot of places where stay hydrated is not a question that is not something you can advise someone to do and actually expect them to be able to do it. And I think that's going to become more of an exacerbated issue over time. And dehydration does predispose you to kidney stones. It predisposes you to prerenal azotemia, it predisposes you to acute kidney injury. So I think that loss of water quality will absolutely result in more kidney disease. I think if we do not develop alternate forms of kidney replacement therapy or more efficient ways to do dialysis, the demands of water for dialysis are going to become a huge problem. In the setting of natural disasters, there are great images of, well, not great, they're horrifying / great images of huge tankers of water being brought up to dialysis units to dialyze people after hurricanes in Houston. I would imagine the same occurred in Katrina and in Puerto Rico as well. I think that as we see, and you could correct me if I'm wrong, my understanding is that we're going to see more water but less functional water, so to speak. Like we're going to see more water but less usable water. And so I think that that's going to exacerbate inequalities because access to good drinking water is currently an incredibly unequal space. And I think in terms of more water, that's going to cause more water-related disasters. And I didn't really get into natural disasters here, but natural disasters kidney patients are one of the most vulnerable groups. My patients are one of the very few people who are on ambulatory life support. They're using a machine to sustain life. If you are a dialysis patient, you do not receive dialysis, your life expectancy is in probably about 1 to 2 weeks. So as you disrupt access to care, I think that you will see that get worse. Yeah. Other questions? All right, I think, oh yeah.
Oh, sorry, do you know if there are any resiliency efforts being built for dialysis patients when natural disasters do strike?
There are. So their dialysis is a little bit unique in how regulated it is. And within that space, there are networks that come together. So the first two, I would say, are the ESRD network. So every dialysis unit reports to like a regional ESRD network. And so that's one of the first places that you can look. There's something called CASER, which is the Kidney Coalition of Emergency Response. And so that's another group that is available to help coordinate response. There's a good and bad to the duopoly that is dialysis, where dialysis is largely operated by two large chains. But the good half of that is that they have a lot of internal systems. We were talking about this a little bit earlier. I don't think that a lot of these things existed a long time ago, or not a long time ago, a moderate time ago. I think that if you're looking back 20 years, you give the example if I did my training in Philadelphia and I saw a patient who was displaced by Katrina who was dialyzing in Philadelphia, and I remember thinking, wow, you got displaced quite a way from New Orleans to Philadelphia, and turns out there is quite a way more that people have been displaced. So I think that that is getting better. We do try to prepare patients, particularly those who are in areas that are kind of recurrently impacted. Patients in Houston, patients in New Orleans typically will have about a week of potassium binders, other medications on hand, are told to have lists of their medications. Like they're told to keep essentially a go kit that has their dialysis script, their medications. So there is a lot that is being done. There sure could be more, but there is a lot of, particularly through the ESRD networks, the American Society of Nephrology, and I'm sure there are some others who would be upset that I did not mention them right now, but there are consortia and coalitions to help people in crisis. Yeah. Yeah.
This is definitely a niche question and probably one that hasn't been researched that much. I was just wondering, in terms of like dialysis water, there is like a certain amount of like sodium concentration, and I guess there are desalination efforts like right now that are like pretty energy intensive and aren't necessarily the most environmentally friendly, but in terms of getting to the sodium concentration that you need for dialysis, I would assume it's less energy intensive to use desalination plants for that type of water. I don't know if there's any like current news on that, or if there's been movements to use that type of water for dialysis treatment.
Interesting. So what I will say is that basically we start with tap water and we run it through carbon filters, run it through reverse osmosis. Typically we'll UV radiate and kind of reconstruct the water from what is potable water into something that's safe for injection. I don't know about upstream desalination. I would imagine that like centralized desalination plants would be too centralized. I don't know if there is a portable technology that could be implemented within a water room to decrease the resource demands. Honestly, it's not something that I'm knowledgeable enough to give you a good answer on, but I'm curious to look into it more. Yeah. Awesome. Well, I will let you all get some coffee or something before the next talk. Thanks, everyone.